afternoon. Once again, KMI Taman Desa Medical Center is organizing another CME talk on dog QT. And I'm looking here now, we have about approximately 100 participants. So without much ado, let me introduce our speaker today. He is Dr. Jeyaraj Navaratnam, obtained his MBBS and MRCP respectively in 1993 and 1998. He has special interest in geriatric medicine and hence pursued his subspecialties in ECU Western Australia in 2008. He has been practicing as consultant physician since 1998. He had geriatric subspecialty training in UM and was a lecturer in geriatric medicine in UPM. He is currently working as a resident general physician in KMI Taman Desa. Let me have a little bit of introduction about the topic today. Yeah, literally we're talking. This topic it will be. I think for those who have parents at home, I mean, elderly at home, this is actually very much close to our heart. Okay, let me have some introduction. The statistic that I gotten from WHO. Dementia is a syndrome where there is a deterioration in cognitive function beyond what you might expect from the usual consequences of biological aging. Although dementia affects mostly elderly people, but it is not an inevitable consequences of aging. Based on WHO statistics, currently there are more than 55 million people living with dementia worldwide. And there are nearly 10 million new cases every year. So without much ado, let us welcome our doctor today, our speakers today, Dr. Jaya, on this topic on how to diagnose dementia in primary health care. Doctor, the floor is yours.
Okay, all right. Thank you very much, Louis and Fiona. Good afternoon, everyone, and thanks for having me here today. The topic of my talk today is dementia, identifying dementia from the GP point of view. It is a bit of a long lecture, so I would like to concentrate a little bit on the diagnostic point and talk a little bit more on treatment options and management of the complications of dementia. Now, without much ado, let me get the slides on. Okay, so what are we going to learn today? We're going to learn a little bit about the diagnostic criteria for dementia, the prevalence and the types of dementia that we will be able to see, what actually happens in dementia, what are the clinical domains involved, what are the clinical scales that we use, the diagnostic methods and treatment. Now, a dementia comes from the Latin word meaning demens, which means out of mind. And the guideline developers have decided that perhaps dementia might not be a good word, and there's been movement away from using dementia. However, dementia is very widely known. And news that Tun Badawi has dementia, there are a lot of newspaper articles and a lot more interest in dementia. So changing the name might not be a very good option. Now, dementia, you must also know, is a symptom, it's not a disease. And generally, we think of dementia means someone is losing their memory. There are many causes of dementia, and the most common one which we're going to talk about today is Alzheimer's. The diagnostic criteria that we use to say someone has dementia is based on the DSM-5. And I would like to spend a bit of time elaborating on DSM-5 for dementia. So let's go ahead and have a look. Yeah. Okay. So now in dementia, it's subclassified into major and minor neurocognitive disorder. Now, major would mean that the person has dementia, plus the person is not able to function independently. Whereas minor neurocognitive disorder, also called NCD, mild NCD, means that the person also has certain features of dementia, but is able to function. Previously, mild NCD used to be called mild cognitive impairment. So we have a whole spectrum where you have normal memory, then you have mild impairment and major impairment. And the major impairment is where technically we are known as dementia, with what we understand with memory loss. And mild is a person who's a little bit more forgetful. So there is a slow spectrum, just like how we talk about high blood pressure, where you have normal high blood pressure, pre-hypertension, stage 1, stage 2. So it's somewhat similar. So what are the criteria to say that a person has dementia? This is your DIMS-5. So what it tells you is, if you look at the first part, the person with dementia must have one of the domains being involved, which is learning and memory, language, attention, motor function, or social cognition. Now, as medical students, when we were in medical school, when we talk about neurology, we always focused on strokes. We're focused on Parkinson. We'll be very interested in someone who has speech abnormalities or also peripheral neuropathy. But rarely do we focus on cognitive disorders because, number one, it's difficult to obtain a decent history from a person with a cognitive impairment. And two, they may not be cooperative. And most of the students would be abhorrent if we produce a case of dementia and ask them to clock it as a long case in the exam. Generally, we focus on the other things that we've talked about. Now, in dementia, we are looking at those exact fields that we missed or we did not pay much attention to in medical school. So if a person, if one of your patients has any of this number 1 to number 5, and there's also another one called number 6, where it is executive functioning, and they have this impairment which is slow and gradual in onset, it is not better explained by some other condition, and it is usually irreversible. If they follow this pattern, then you can safely say that the patient has a major NCD. Now, going on to the next slide, it's basically similar to the first one, where the important thing is the patient themselves may say that they have a cognitive impairment, but you have the same 5 domains being involved. It's slow and gradual, it's progressive, it's not better explained by some other condition like a depressive episode or psychosis, and the patient is able to function. So you're looking at, in dementia, you're looking at higher mental functions, which is your number 1 to number 5, plus whether the patient is able to function normally. Now, going on, so the next section now, I'm going to talk about those 6 domains, and I'm going to place a little bit of emphasis on memory. So what is memory? Memory is actually a process of encoding, storage, and retrieval. And when you talk about memory, you're going to have a bit of confusion depending on the articles that you read, because memory is talked about by neuropsychologists and is also talked about by neurologists. And we have always been trained by neurologists. And certain words like encoding, storage, retrieval, this is from the neuropsychologist point of view. Now, there are 2 theories of memory, which we're going to talk about. The first one is Atkinson and Shifrin's model, 1968, where we are talking about memory as a series of blocks, like a computer. So you have memory where you have sensory input coming in, and it's called sensory memory. So all memory is formed from something in your senses. Either you see, either you hear, you touch, and that forms your memory. Once that forms your memory, and then if you pay attention to it, it goes into your short-term memory and it goes into your long-term memory. So we're familiar with this. Now, let me give you an example. Think of what did you do this morning? When you drove your car from your house to your clinic or to your place of practice, you would have passed through a lot of other cars, a lot of traffic, but you would not have paid much attention to it, am I right? So that is your sensory memory. Your sensory memory is your brain picking up in every microsecond all the things that you see, you hear, you touch. Most of your sensory memory is lost. It goes into forgetting or goes into decay. But when you pay attention, for example, when you're driving and you see an accident, well, your attention perks up. And when you pay attention, that piece of memory goes into short-term memory. And if you keep thinking about it, if you rehearse it, then it goes into long-term memory. And then when you want to remember, you retrieve it back and it comes back into your short-term memory. Now, this whole process occurs in the neocortex. And this process is what is primarily involved in Alzheimer's disease. Now, another theory of memory is by Bedley and Hitch in 1974, where he proposes that your short-term memory, also called a working memory, has got many different sections. So if you look at the slide, you can see the long-term memory, LTM, and all the other part on top that you see, your central executive, your visual sketchpad, your phonological loop, all this forms part of your working memory. Now, to understand this matter, I would like to ask you a question. Now, all of you participants, can you just think for about 10, 15 seconds and tell me in your mind, or just jot it down, how many windows are there in your house? All right. So when you think about such an instruction, how many windows, you are trying to retrain your memory or retrieve from your memory. And what you would have thought is you would have had a mental picture. Am I right? You would have thought of your house. You would have gone from room to room, counting 1, 2, 3, 4, and you would come with an answer. So that is what Bedley and Hitch is talking about. A visual spatial sketchpad is a picture, a mental image of what you store in long-term memory. And a phonological loop is what you think in your mind, auditory, and you come out with an answer. So these are two theories of memory, both which are in the realm of the neuropsychologist. And it's very interesting because we can use this to understand how people think, how we form memory, and what we can do. Now, an interesting concept which I would like to show you is when you look at the brain, you can see that the working memory or the short-term memory is focused on the prefrontal lobe, and you have the Broca and Wernicke's area which forms the loop, and you have the occipital lobe which forms the visual spatial sketchpad. So all these parts of the brain are involved in your memory process. Now, going on, again, a much simpler slide where you're talking about your sensory input, your eyes, your ears, your sensation, whatever information is in your sensory input goes into your working memory, it goes into storage, it goes into long-term memory. And if you rehearse, if you keep rehearsing, if you keep retraining yourself, it goes into long-term. And when you retrieve it back, it comes back into your working memory. Now, I would like to also reiterate that when you are forming memory, when you are remembering something, there are a lot of other factors that are important. For example, how you feel at that time, or external factors. What is the weather like, or what did you eat, or where did it happen? And these are called cues, retrieval cues. So for example, when you look at a patient in Alzheimer's, when you want them to remember, you take them back to the place that they know. For example, you take them back to their own house, or you show them an old photo, then they will tend to remember. And these are called retrieval cues. So like in a very funny study that they have done, they found that people who are drunk and then they lose their keys, they're not able to find the keys when they're sober. But if you put them back in the same situation where they get drunk again, they are able to remember. So memory, when memory is formed, it depends on a lot of external and internal factors that goes on. And this is very important when we are dealing with patients with dementia, because we try to recreate the situation. So in a patient with dementia who's agitated or is not able to remember, you try to do reminiscence therapy. That means you try to arrange their house in a way that it's familiar to them. And you tend to play songs that maybe from the 1950s and 60s, which they are familiar with. And when you do this, they're able to remember their agitation or their abnormal behavior comes down. And I thought that this is a very interesting point that we should know, that using retrieval cues can help in behavioral and memory therapy for people with dementia. Going on, this is the forgetting curve of Ebbinghaus. Ebbinghaus was a neuropsychologist who discovered that we tend to forget. And if you look at the line here, you would find that when you learn about 100%, 100 points, and that within the first hour, your retention is only about 38%. And if you do not reinforce, if you do not rehearse and go back to 100%, that memory goes off very quickly. So if this, the reason I'm showing this curve of forgetting is that when we are dealing with, or when we are teaching our children, or when you are teaching your patients, they would tend to forget what you tell them. So at the end of your consultation, or when they come to the next day, when you're talking about only dementia, when you're talking about educating them on diabetes, or when you're talking to children about their history lesson, you would want to repeat what you have taught and ask them to recollect and ask them to discuss and talk about the topic so that the memory is retained. And I thought this was an excellent article by Ebbinghaus. And if you have time, if you can just go through and read about Hermann Ebbinghaus and his experiments, then you find that there are many strategies that we can use to teach our patients, to educate our patients, and also to educate those patients with early Alzheimer's or mild cognitive disorders. Okay, going on. Which part of the brain is involved in memory? Well, we have the amygdala. Amygdala, if you remember, is the princess in Star Wars. Yeah, so that's where they got the name. And amygdala is this small piece of tissue in front of the hippocampus here. And amygdala adds emotions. So we know that if you want to remember something, the emotions associated with that memory process makes that memory easier. For example, anger makes you remember. Fear makes you remember very well. So certain emotions are related to better memory retention. Next to the amygdala is the hippocampus, which forms part of the limbic system. Again, the limbic system is always something that we never focus on in medical school. And the hippocampus is a very important organ which is involved in short-term memory. And in patients with Alzheimer's, the hippocampus and the lateral temporal lobe, where the hippocampus is located, is involved very early in Alzheimer's. And that's why you would tend to find patients with dementia, Alzheimer's type of dementia, having memory and inability to remember reason stuff as a problem. Now, apart from the amygdala, apart from the hippocampus, all other parts of the neocortex are also involved. And certain parts like the cerebellum and the basal ganglia are involved in implicit or declarative memory. All right, so memory is a huge thing, and different parts of the brain are involved. I thought I would actually spend some time on memory because it's something that we do not really focus on in medical school. So going on, this is a picture which I took down from the net. It looks like a spaceship again. Amygdala, Star Wars, something very strange, a character, but this is what we have in all parts of our brain. We have the amygdala in front, we have the hippocampus, we have the cingulate gyrus, and all these are part of the limbic system, is involved in memory and behavior. Right, going ahead. This is an MRI of a patient with Alzheimer's disease, and you can see the area coded in pink. That is your hippocampus, and you can see the corresponding area in a person with Alzheimer's disease, and there's obvious atrophy and shrinkage of the hippocampus, and there's also a lot of cerebral atrophy we see all around with widening of the ventricles. Now, can we use the MRI as a tool to diagnose Alzheimer's or any kind of dementia? Yeah, perhaps, yes. With the latest MRI, there have been movement towards having strict guidelines and also specific ways of measuring the cerebral volume and specific areas of the brain, which may be used in the future after validation to diagnose, or as one of the additional tools to diagnose dementia. Okay, going on beyond memory, now we have language problems also in dementia. And in certain dementias like frontotemporal dementia, language problem is prominent. And if you look at your mini-mental state examination, your Falls-Ins mini-mental state examination, language is involved when you do naming, verbal fluency, comprehension, reading, writing. All this is involved in the language function. So when you're testing this, when you're using the mini-mental state examination, you are able to test the language. Now, if you look at common language problems, you would see that paraphasia is a common language problem. Paraphasia is where your patients with dementia would tend to have a change in the words that they use. Like semantic means knowledge. So instead of using cat, they would say dog, or instead of saying paper, they may say something else like chair. So which means that they have semantic paraphasia. Phonemic paraphasia means they have problem with the phonemics. So which means that instead of saying cat, they may say dat, or they may say pet. So it's a change in the phonemics of the word. Now, circumlocution means that patients with dementia, they can't get the word. So when you show them a chair, they can't get the word chair. They would say, it's something that you sit on, you know, or you show them a book, they say, there's something that you read, but they cannot get the exact word. Or they will also use neologistic paraphasias, where it's their own creation of their own words. So when you talk to a patient with dementia, you would know that one, he's having his own words, he's having a difficulty in explaining himself, he's using different words, he's misidentifying things. Now, a very simple way of looking at this is just having a chat with the patient, talking to him, and then you can know whether are they fluent, and if they're fluent, are they talking sense, or are they using their own words? And very quickly, you can find out that there's something wrong with this person. Now, I would like to show you this next slide, where you can see that a simple test of naming, okay, and the person, like say you want to name a pencil, or you want to name a pen or a watch, like what is done in the mini-mental state examination, you can see you go through a series of process. So now, if you see a spoon, now what happens? When you see a spoon, the light strikes off the spoon, and that's in a wavelength, and every object will vibrate at a certain vibration, and it will absorb the different vibrations and only reflect the same vibration. That's why you would see a red object as a red, because all the other colors are absorbed. Now, the light strikes your retina. From the retina, it goes to your optic nerve, optic chiasma, then it goes to your lateral geniculate body in the thalamus here, and then it goes to your optic radiation, optic cortex, occipital cortex. So from the occipital cortex, the information goes to various parts of the brain, and what comes out is the word spoon. So it is done in microseconds, milliseconds, but the next slide will show you the different parts of the brain that are involved in a series of events for you to name. So when you ask your patient to name a pen or name a pencil or a watch, all these parts of the brain will tend to light up, and they all have to work in unison. So a very simple test. How difficult is it to say, tell me what is this, tell me what is that? And they're not able to do it because all these areas would be involved in various stages in Alzheimer's disease or various other forms of dementia. Okay, the next domain that we would test would be complex attention, which basically means the ability to focus on one or multiple tasks. And the test that we commonly use is either the serial 7. Again, this is in your mini-mental state, where you ask them to count from 100 -7 -7 up to 5 numbers. or you ask them to do a digit span. This is seen in your MOCA. MOCA is your Montreal Cognitive Assessment. So these are the two clinical scales that we use. Or we ask them to spell the word backwards, spell the word, either dunia in the Malay mini-mental, or in the English mini-mental, you use the word world. Now, the magic number in complex attention is 7, because psychologists have found that most humans are able to remember 7 numbers. And that's why your telephone numbers are usually 7 numbers, and plus minus 2. Anything beyond that, person would tend to have difficulty in focusing. Again, attention, there are many kinds. There's divided, selective, sustained. Sustained means the ability to focus on a particular event, like this number 7 number, 7-digit span. Divided attention is what your teenage son or daughter is able to do, which means it's multitask. They're able to look at the phone, able to eat, able to do their homework on their PC or notebook, and listen to music at the same time. So this ability to multitask is divided attention. And you know that the divided attention is impaired as we grow older, even in normal aging, and it's impaired to a significant extent in persons with dementia. So when you have multiple things that you ask a person to do, so when a dementia person is going to read the paper, and then you ask them halfway to switch off the fan or switch off the light, they would forget to read the paper and maybe switch the light only, and they don't know what they do. Or if you give them multiple tasks, they will not be able to do the task specifically. And that is why they would tend to again not switch off not switch off the lights, or keep the stove on, or keep the cooker on, and that will lead to problems. So one of the ways you can deal with this is to give a person with dementia very simple one-step instructions which are able to carry out with confidence. Executive function is a function of the frontal lobe and also other parts of the neocortex, where they are not able to do a complex action. For example, like pay the bills, drive the car, read a book and explain, and so forth. So how do we test executive function? Is by doing something called the clock drawing test, which again is a very simple test that all of us can do. Is that you ask the person to draw a clock, or you can draw a circle and ask the person to fill out the numbers 1 to 12, and put a time. The usual time is 10 minutes past 11. And you can find out that as they progress, they'll have problem in their visuospatial abnormalities, and they won't be able to draw the clock, or they put the numbers wrongly. Another test that we do is called the trail making test, which you can download. All these tests are available online. You can download. And a trail making test is where they have to join a number of series of numbers. And this requires a bit of attention. Going on to 2 other domains is that we have social cognition, which basically means the ability to behave appropriately in society, which means you don't go to the beach wearing a 3-piece suit or a tuxedo, and you don't go to a dinner party wearing short pants and singlet and so forth. So inappropriate behavior in the proper social standing on the proper environment, that is called social cognition. So you would find that your patient with dementia may be acting inappropriately. A person who's quiet now is very gregarious, very noisy. And a person who would have been last time very, very jovial, maybe will be acting inappropriately in the situation. So that's social cognition. And finally is perceptual motor function. We're talking about a person not able to find his way, gets lost in visuospatial, gets lost in the environment, not able to do things like praxis. A praxis basically means that they're not able to do a motor function, but they have normal motor or pyramidal, extrapyramidal, cerebellar systems are fine, but they're not able to do a motor function. Very simple. What they do is I give them a comb and ask them to show me how they comb their hair, give them a key, show them how they use the key, and they're not able to do this. So praxis means it's a Latin word for process, where they can't do a motor process, and agnosia is the corresponding sensory part of it, where the sensation is intact, but they're not able to perceive. Now, if you look at facial agnosia, that's called prosopagnosia, and we know that there is a particular part in the temporal lobe called the FFA, fusiform face area, which is important for us in that is the area of the brain where we recognize a person's face. So if we show Tun Mahathir's face, we're able to recognize. If we show our parents' face, we're able to recognize. So studies have shown that in Alzheimer's disease, because the temporal lobe is involved, the facial area, the FFA area is compromised, and patient is not able to recognize other people. So now let's put ourselves in the place of a person with dementia, right? Now imagine a person with dementia. He's sitting at home at night. He's had his dinner and he's gone to read his newspaper. Now he sees you walking in. Now when he sees his son walking in, all right, the dementia patient is sitting there. Immediately he sees the son, but his FFA area is not working. So he doesn't see his own son, or he doesn't see his daughter or his wife. He sees a stranger. Now, you or us sitting at home, comfortable at home, and suddenly we see a stranger at home, what do? It's probably a robber, isn't it? So what we're going to do? We're going to shout, scream. We're going to get the phone. We're going to be very agitated. So that's what happens to a patient with dementia. They cannot recognize, they cannot see. So they cannot recognize their wife who's been with them all the while, or their children. They see a stranger and they start getting agitated, shouting, screaming. And what does the son or daughter do? They will tend to come nearer, isn't it? They will tend to come nearer to the father or mom and try to calm them down, which will actually make the situation worse. So the idea is to inform, or for us to understand why a dementia person reacts the way that he or she does. And once we know that, then the way we treat them or the way we approach them is much easier, because we can see it from their point of view. So these are the 5 or 6 domains that are involved in a person with dementia. And now that we understand a little bit, so when you have someone coming to you, either the family member or the person himself saying that they have a problem with memory, and then when you take the history from the caregiver or from the person, definitely you must look at the caregiver. You will be able to understand the domains that are involved. And using the mini mental state or using the MOCA, you're able to a little bit more add value and confidence to what kind of dementia, or whether the patient has dementia, or is it depression, or is it normal aging. Yeah. So now we go on to the next part, where what happens between normal aging and in a person with dementia. Well, we know that in memory, in healthy aging, the key word is minimal decline. And that's why now we can understand why Tun Mahathir, being 96 years old, seems to have full cognitive ability to run the country, as he did about 2 years ago, because his memory is still pretty much intact. In terms of attention, as we grow older, in normal attention, it is divided attention that decreases slightly. So we're not able to multitask, but we're still able to pay full attention to most of the other things. Executive function, very mild decrease. Language, very mild decrease. Visuospatial, we can do most of the things. We can drive the car, but we do it much more slowly. So if we can drive perhaps in a less traffic prone areas, but we would have difficulties driving in a high density area. Intelligence. Intelligence has 2 types. We have crystallized intelligence, sorry, wrong spelling, and also fluid intelligence. And crystallized intelligence means that our ability to reflect and give an opinion or an analysis based on what we know. So crystallized intelligence actually improves with age. Fluid intelligence means much more rapid changing environment. Fluid intelligence peaks at about 40 years. So that's basically, so what I would like to say is that in healthy aging, your memory does not deteriorate. And that's important to know. Okay. Now, as Louis has reiterated earlier, there's a lot of information on dementia, a lot of statistics going on. But a very interesting point I would like to make is that the number of cases with dementia is definitely going up because more people are growing old. However, as a percentage, between 2011, in 2011, the incidence of dementia was 11% in people above 70. And in 2019, before COVID, this had come down to 10%. That means, although people are growing older and there are more people with dementia, in terms of new cases per population, it's actually decreasing. So with better healthcare and with better education, the chances of us or you and me getting dementia is actually reducing, which is a good thing. However, whenever you read news articles and journals, we have to start up with sensationalization, which means we have to grab public's attention. So you would have that 100 million dementia cases are coming, 200 million cases are coming, and so forth. However, you look at the data, although the number of cases are increasing, the chances of a person getting dementia is actually reducing a little bit, and that's a good thing. Okay, when you look at dementia, there are many various types of dementia, but the most common is Alzheimer's. Frontotemporal is seen in younger persons. Vascular is because of pre-existing hypertension, diabetes, and so forth. So what you need to know is in the next slide, I would think that if you look, the most common dementia is Alzheimer's. The next most common is vascular. And about 8% is a mix of both of these, and only 16% is others. Now, this is looking at Europe, and this is looking at people above 65. Now comes the bad news. Dementia, although it occurs in people above 65, in about 5%, it occurs in people below 65. And in those below 65, we have to be a bit careful because Alzheimer's disease is about equal with frontotemporal dementia. So which means there are other more common, other dementias coming in. And if you suspect your patient is having dementia based on abnormal domains and dysfunctional, then I would think a very important point is how old they are. If they are younger, in their 40s, 50s, what I do is I need to refer them off. I need to refer them to a center which has neuropsychological testing and the ability to have multidisciplinary care, because chances are they may not have Alzheimer's, they may have other kinds of dementias, which are a little bit more challenging. If you look at frontotemporal dementia, the youngest person, the age range goes from as young as 29 to as old as 80. And if you look at people who are younger than 65, as I said, temporal dementia, FT dementia is almost as common as Alzheimer's disease. So that needs a little bit more of expert care. Yeah. Okay. Now, going on, most of the Alzheimer's dementias we see average age is about 75, and survival is about 8 years when they're diagnosed in their 70s, but it reduces if they're diagnosed much later. And delayed diagnosis is because there's a delay. It's about two to 3 years before patients are diagnosed with dementia. The reason being is that family members do not recognize, even we do not recognize, because when we see a patient for too long, sometimes we think that's part of normal aging. And sometimes we feel that nothing much can be done. So why go through that? Yeah. Okay. Now, the next series of slides is about Alzheimer's. Alzheimer's was a German neurophysicist, neurologist, who described about the first case, Auguste Dieter. And dementia was known before then. She was not the first case. But what Alzheimer's did was that this patient was having features of dementia at a younger age, at about 50 plus. And she passed away after about 3 to 4 years. And interestingly, when he did a post-mortem analysis and he found two things in the brain of a person with Alzheimer's or dementia, Alzheimer's type dementia. And this is still holding true, that the presence of senile plaques and tau proteins, neurofibrillary tangles, are the hallmark of Alzheimer's disease. And I'll talk a little bit about it, very, very brief. So this is a picture which I downloaded from the net, and we can see that there's a cell body, there's a dendrite, and an axon. Okay, three things are happening. One is the pinkish stuff called amyloid, and amyloid is deposited in the brain. Two, you can see those tangles which is deposited in the cell body and also in the axon. The tangles, the amyloid, and these are microglial cells which elicit an inflammatory response. So in a patient with Alzheimer's type of dementia, there'll be three features. Two features which are very well seen: your amyloid, your tangles, and your microglial activation. Now, going on, again, another very quick diagram. When we look at the cell body, nutrients have to go from the cell body to the axons, and they travel along these tubules. The tubules have these tau proteins, TAU, tuberculin-associated proteins. If the tau proteins are damaged, then the microtubules are not able to function, and nutrients do not travel from the cell body to the axons. So that causes cell death. Okay, so now why does the tau protein get destroyed? It undergoes a process called phosphorylation, and this is stimulated by your amyloid plaques. So maybe, not very sure, maybe. So your amyloid plaques cause disruption or phosphorylation of your tau proteins, which causes destruction of your tubules. So the nutrients can't go from the cell body to the axons. So the cell undergoes cell apoptosis. Yeah? Now, what are these amyloid bodies? These amyloid bodies are actually proteins, amyloid precursor proteins, which are seen in your cell membrane. All of us have this. And for some reason, because of different kinds of enzymes, we do not have to know them, but different enzymatic cleavage causes abnormal proteins, which is called A-beta 42 proteins. And these proteins would congregate and coalesce, and they cause a dysfunction in your brain. And this is what Alzheimer's saw about 120 years ago. Your amyloid plaques, which are this pinkish stuff, and your neurofibrillary tangles. But what happens basically is there is cellular death, cellular apoptosis, and cellular death, and the cells, neuronal cells, fail to function. For some reason, in Alzheimer's disease, it starts off in the medial temporal lobe, which is involved in your short-term memory. So memory goes off very early. Whereas if you look at frontotemporal dementia, it's mainly in the frontal and the temporal lobes. So different parts of the brain, different domains are involved. But in Alzheimer's, it's your middle temporal lobe. Okay, now this is an important slide. If you can just have a look at it. So what it's showing is, if you're looking at all these various red, blue, and green lines, what it basically tells us is that if you're looking at amyloid here, by the time amyloid collects quite significantly, in the brain, only then you have clinical deterioration. Studies have shown that amyloid and tau proteins start collecting about 20 years before the onset of clinical symptoms. So now you remember that clinical symptoms on average start at age 75, which means your amyloid is already being deposited at age 50s. And we only start treatment when we have symptoms. So we do not start treatment in the early stage. Okay, so perhaps that is why treatment for dementia that's available now is not very successful, because the damage has already been done. So a lot of research over the last 30 years has focused on treatment at an early stage. So how do you know which 50-year-old man or lady has amyloid, which can cause dementia in 20 years? So they have discovered, they have discovered that various imaging techniques and various biomarkers which are available now in research centers has the ability to pick up Alzheimer's at an early stage and hopefully start treatment. All right. So the future looks bright for Alzheimer treatment and prevention. And the next few slides, we will talk a little bit more on this. Now, what is the role of genetics? A very simple slide. Those early onset dementia, which is due to Alzheimer's, usually below 65, and they have three genes which are more prone, is seen more in families: your presenilin 1, presenilin 2, and your amyloid precursor protein gene. So these are three genes which you can test, not available here, which can tell you whether there's a higher probability of you having dementia. Again, this is more often in familial dementia. And in late onset dementia, there's a gene which I've not mentioned here, which is called the ApoE. You know that ApoE is a gene, it is a protein involved in lipoprotein metabolism. And those persons with ApoE4, you have 2, 3, and 4, those persons with homozygous ApoE4 have a higher chance of getting late onset dementia. Not that they must, it's just that a higher chance. And this test is available in certain genetic labs in Malaysia. Okay, going on, what are your risk factors for getting Alzheimer's disease? Of course, it's age. And the older you are, the higher the chance of getting dementia. Higher education level protects against Alzheimer's. Recurrent head trauma and the abnormal genes that I've mentioned earlier are associated with higher incidence of getting Alzheimer's disease. And if you want to know what is the current magic treatment, which can delay, prevent Alzheimer's disease to a certain extent, the current magic treatment, which I'm going to tell only you, which can be used to prevent, delay Alzheimer's disease, is called exercise. Exercise, half an hour, moderate intensity exercise, minimum of 5 times a week, has been proven to delay the onset of Alzheimer's disease. This is currently the only magic drug currently which can prevent Alzheimer's disease. All the rest are just symptomatic. So you may want to be like Po. If you remember the cartoon character Po, the panda, and the magic in the noodle, the secret of the secret noodle is nothing. Similarly, the treatment of choice for Alzheimer's disease at this point is exercise. And I like to say it again and again, because exercise has been proven to reduce your chance of vascular dementia, Alzheimer's disease, reduce your chance of cardiovascular disease, improves overall well health, and decreases depression, and improves longevity. So exercise, I think, is the key word. Okay, going on to clinical diagnosis. Well, you need to, number one, get the history of the domains. You need to get a history from the caregiver. You need to look at what are the medications the patient is taking. And there's a criteria called DBS criteria for elderly people, where you need to go through and see, take a history of what the patient is what medication the patient is taking. Once the patient has gone back, you need to research and see whether any of these drugs are capable of causing cognitive decline. A clinical examination would mean a neurological examination. A clinical rating scale would mean either you do a mini mental or you do a MOCA, and then certain investigations which we will talk about. Very basically, the previous thinking is when you handle patients with dementia, you need to exclude treatable causes, which is you're looking at thyroid, B12, VDRL, which means syphilis. These are all outdated guidelines. When you're doing an imaging to make sure there is no space-occupying lesion or hydrocephalus. This is not the way we go through now. Now it's more positive points rather than ruling out points, but it's important to consider this. The clinical rating scales that we use is the mini mental. The mini mental is available also in the Malay version. So if you are able to access, just type in KKM's dementia CPG guidelines. In the annex portion, there is the Malay version of the Falstein's mini-mental. The Cantonese version is available online. And the original Falstein's mini-mental examination was actually meant for English-speaking population, but with ability of the vernacular types, then we have other kinds of other language Falstein's test to be able to be used. Not the Minnesota, sorry, the Montreal Cognitive Assessment Scale again is available in a Malay version and also in an English version. And if you have time, if you're very conversant with 1 and 2, then you can use the latest one of Edinburgh Cognitive Assessment. Again, it's just been validated in a paper released recently by Professor Sharol in UH and colleagues, where the Edinburgh Cognitive Assessment Malay version is a bit more detailed. It is able to be validated and used for the Malay language, and Edinburgh originals in the English language. So these are 3 cognitive assessment clinical rating scales that we can use. I would recommend MMSE as a start off, or even MOCA. And once you're familiar with this, then maybe you would like to download the Edinburgh and use it, because that gives you a little bit more detailed information. Yeah. Okay, so are we able to do any blood tests? No, unfortunately, not right now, but we can use lumbar puncture, and you can identify certain proteins like the total tau, phosphorylated tau, or the beta amyloid 42. These are 3 proteins which we talked about earlier. Different levels of this are found in the CSF fluid, and in certain memory clinics in Europe and in Canada, they do use this as routine in certain memory clinics to identify early stages of cognitive decline. And looking at imaging, looking at PET-CT, where the PET-CT for tau, they can detect tau protein and also detect amyloid. You're looking at a region of about $6,000 to $12,000 for each imaging technique. It's not covered by Medicare or Medicaid, so it's self-pay. Needless to say, it's not available here. And the next 3 slides, I'm going to show you a little bit. You can just see the difference between the amyloid in a person, a normal person, and in a person with Alzheimer's. Now, the presence of amyloid alone is also seen in people with normal cognition. So it's not automatically associated with Alzheimer's disease, but the presence of amyloid points towards more chance of getting Alzheimer's disease. And you can see the difference here between a person with typical AD. Exceptional ager is a person who has ApoE, which means got a higher risk of getting Alzheimer's, but you can see that the brain, there are minimal amyloid deposits. And again, the next slide shows you the different amyloid deposits in different kinds of dementia. This is Alzheimer's disease, this is control, and this is corticobasal, a different kind of dementia where you do not see so much of amyloid deposits. All right. So now if you look back, the question that we discussed earlier, which kind of that amyloid deposits and tau proteins are deposited at least about 20 years before the onset of symptoms. So if we can use this kind of PET-CT scans, and if we can use biomarkers in certain people at high risk, then we can identify those people in the early stages, and maybe we can institute some kind of treatment. Now, the next section we're going to talk about, going through a little bit quickly now, is looking at 3 kinds of modules of treatment available. One is cognitive or memory enhancers. The other one is immune modulators. And the third one is behavioral modifiers. Yeah. So very quickly, as we're running short of time, we know that the thing in Alzheimer's disease is that cellular apoptosis because of tau and amyloid. Currently, we can't do anything about tau and amyloid. But once cell death occurs, and because it occurs predominantly initially in the temporal lobe involved in memory, they found that acetylcholine, is one of the neurotransmitters involved in memory. And by giving medication called cholinesterase, anticholinesterase, we prevent the breakdown of acetylcholine. So using such medication prolongs the action of acetylcholine in the synaptic cleft and improves your memory. So that's the teaching. All right. Okay. So what are the medications available? The medications available are donepezil, rivastigmine, and galantamine. These are 3 medications available in Malaysia. It's been available for some time, for the last 20 years. And these 3 medications can be used in dementia. Initially, it was only used in mild to moderate, but now donepezil is approved for severe cases. And in the last column here, I have put the approximate cost of the medication for 1 month supply of treatment. So would you use this? Yes, I would use this for patients in early, mild, moderate, severe cases. I will also use this in patients with behavioral symptoms because it does improve. However, there are a few caveats. One, it's expensive. It has side effects. And you must use very, very low doses. Like donepezil, I start with 2.5. And then I would usually increase it at monthly intervals until the maximum tolerated, which is 10. There's also a dose for 23, single daily 23 milligram dose. But in my experience, it causes too much of side effects, and I usually focus only with 10. Rivastigmine and galantamine I rarely use. It's much more expensive. Now, there's another drug called Momentin. Now, Momentin is different from cholinesterase inhibitors because apart from acetylcholine, there's another neurotransmitter called glutamine. And Momentin antagonizes the action of NMDA receptors, which glutamine is the main neurotransmitter. Mementamine is allowed in or is approved for moderate to severe. So what I do is usually I give a combination of donepezil and Momentin in severe cases at times, but usually very few because of the side effects. Now, what are the side effects you're looking out for? Is because it's a cholinesterase inhibitor, so acetylcholine action is accelerated. So you would tend to have symptoms of GIT problems such as nausea, sometimes constipation, diarrhea, and patients tend to lose appetite, which is not something you want to see in a patient with dementia because you already have appetite loss, sometimes hallucinations, and they'll have bradycardia because of vagal stimulation. So donepezil, it's a good drug. It can be used for some patients. I need to counsel the family that it is useful, but it's expensive and you must look out for side effects. And it's got a lot of drug interactions. So you can see here, quintaprine, seroquel, escitalopram, trazodone, all these are medications which are usually used to control the behavioral aspects of Alzheimer's disease or psychotic symptoms in Alzheimer's. So you need to be very careful to choose your patients very carefully. But donepezil is the second drug of choice after exercise, half an hour, 5 times a week. All right, so this is a general advice for patients. I would always start slow, avoid other medications which will worsen memory, especially looking at benzodiazepines, avoid drug interactions, and also take only one medication change at a time. Okay, very quickly, right, we go to the next, which is immunotherapy. Immunotherapy, the second drug here is a monoclonal antibody. All these are monoclonal antibodies. The only one in the market is aducanumab, which is by Biogen. I can't even pronounce it properly. And the cost is $56 USD per year. So this is a drug which has been approved late last year by FDA, given specific approval, fast track approval. It's not 100% proven, so they are allowing permission to be started early. It's not available in Malaysia yet. So this is one of the drugs that can be used in early or mild neurocognitive disorders. So it looks very promising, a lot of research which is going on. However, the expense and the long-term efficacy still remains to be seen. Okay, going on to my last slide, behavioral problems. So behavioral problems are what most of us would tend to see, because that is what leads to more nursing home placements, more anxiety, caregiver burden and distress, things like depression, agitation, psychosis. And I had a patient 2 days ago who the wife brought him in because he went home. He went out for a walk and he didn't come back until the next day. Didn't know where he was. All right. And when we did the MMSE, he was disorientated to time, place, and person. He had paraphrasias, and the wife knew that something was wrong with him, but it didn't really strike her until he failed to come home until the next day. All right. So behavioral problems, what can you do? This is the last slide. What you can do in behavioral problems is like agitation, aggression, or even for whichever behavioral problems, look at the second line, is that you need to see, is there an undiagnosed medical problem? Which means, is the patient having pain? Is the patient having fever? Is it due to some undiagnosed medical problem which is causing the behavioral abnormality? Sometimes the patient is having urinary retention, or the patient is not able to BO. So they would tend to wonder because they're finding the toilet, or they get agitated. All right, so look for a simple medical problem. Is it environmental? Is it too noisy? Is it they cannot focus? Is it too much of light in the house? What is it? So is it an environmental? Is the teenage grandson playing music too loud, which is interfering with the grandfather's ability to focus? Look at medication. Did they take any over-the-counter sedatives? Is it depression or is it delirium? So if a patient with Alzheimer's comes to you with some form of behavioral problem, go through the same things. First section is identify what is it? What actually is a behavioral problem? Look at what the underlying cause is. Then comes your management. Now, most of the time, you would like to do pharmacotherapy. That means if the patient cannot sleep, give a sedative. If the patient is wandering, walking at night, tie the patient down, give a sedative, give an antidepressant, give an antipsychotic. Now, there's a JAMA article released very recently which says that antidepressants do not work on the serotonin receptors. They do work, but they're not working on the serotonin receptors, which is one of the cornerstones of why we start antidepressants, isn't it? The newer antidepressants. So things are changing, information is changing. So rather than using pharmacotherapy, maybe we should try to do the other methods. However, I must admit that using the other methods such as environmental, behavioral management, teaching, educating the caregivers, it's very, very difficult. It requires a multidisciplinary team. So in a busy clinical practice, we may have to resort to pharmacotherapy, but it's always better to keep pharmacotherapy until your last event. Okay, with that, I would like to say thank you for bearing with me for the good part of an hour to listen to this talk. I hope I have imparted some bit of information which you may find useful in your clinical practice. The important thing is exercise, which is still the treatment of choice in treatment of dementia. Thank you. Yeah.
Thank you, Doctor. Okay, let's move on to, I can only ask 2 questions because it's already short time. The first question is by Dr. Azlini. Besides, just now you mentioned that even though you actually do a gene test, which is available at APOE4, but yet that the only way to reduce the risk of being Alzheimer or dementia is by exercising. Apart from exercising, is there any supplements that can actually reduce the risk per se?
When I started with geriatrics about 22 years ago, there was a lot of interest in vitamin E. Okay, so using a high dose of vitamin E, which is about 2000 IU, was shown in certain studies to improve or to delay. However, current studies does not show any benefit. Neither does it show any harm in lower doses of 1000. But 2000, yes, there could be some harm. So overall, does it work? No. Is it harmful at high doses? Maybe. So keep your standard dose of about 1000. The other drug is Tanakan, Ginkgo. Again, the current one, the latest as of 2021, only exercise and reduction in all your vascular risk factors, which means control your blood pressure, control your lipids, control your diabetes if you have any, have a lot of friends. The more interactions you have, it improves your brain plasticity. There's a new term that the more you use your brain, the better it is. So the more friends you have, the less chance you get of dementia.
Oh, okay. Okay, second question by Dr. Santiago. Will benzodiazepine taken regularly cause dementia?
Benzodiazepine will slow down your benzodiazepine is like is a sedative. Long-term use, yes, will definitely not cause dementia, but it will slow down your cognition. So whether it fulfills the criteria for causing dementia, I'm not sure, but we try not to use for the long term now. But in the short term, it's used for anxiety and all panic attacks. So it's a useful drug, but not I won't advise it in the long term. Yeah.
Okay, all right. There's two more questions coming in from Dr. Chua. When I look at it, I was smiling. Any study done dementia among doctors?
I'm not aware. I'm sure there are, but I'm not aware of any specific things done on dementia in doctors. Okay. Sorry about it. Yeah.
Okay. Does piracetam or ginkgo biloba or vegan diet have any role in delaying dementia?
Piracetam is a cerebral enhancer. Is used for stroke. It was used for stroke, especially in persons with speech involvement of the speech areas. But it's not in the guidelines for treatment of dementia, and neither is it in the guideline now for treatment of stroke. But I do use it for some patients. I'm not aware whether it has any role in dementia. I do not think so. Ginkgo, similarly, a lot of studies showing that it does help. But again, if you're looking at mainstream literature, no, this ginkgo does not help. Vegetarian diet, surprisingly, very rather good. It does prevent kidney disease. Yeah, that much we know. That the vegetarian protein is safer than animal protein in patients with kidney CKD. But I need to ask the nephrologist on the latest views on vegan diet for kidney disease. But the last I read was it is supposed to be better. All right. Again, there are lots of different modalities we can use, a lot of nutraceuticals. But when you're talking from my point of view, which is guideline approved, a lot of things are still not. Now, I need to make a disclaimer. I'm not being paid by any drug company. And but I am concerned that if you look at the way research is going, it seems to be pushing towards the use of expensive medication. And a lot of industry, a lot of it is industry driven. And we did see it with COVID. So we have to be very careful about what we say in the public domain. So I can only say that at this point, ginkgo and piracetam, the evidence is not there in official channels. But there are many other articles which says it's useful. But I don't use it routinely for my patients. But I do give them the option of doing Tanakan, yeah, which is ginkgo. All right.
Right. I think that's it, Doctor. There's no more other question. So thanks for having you here today. It's a very, very solid presentation, actually. I have prepared quite a number of questions, but then as you go along with your slide, then you literally all answered. All right. Okay, I think that's all for today. Thanks, Doctor. You want to say a few words?
Yeah, I think dementia is getting more common, and I think GPs are a cornerstone in handling patients with dementia, because we cannot be sending all our patients with dementia to memory clinics, number one. And two is what I find is that we need to visit the patients in their house and see what's going on. And I'm very happy that in where I'm practicing now, some of the GPs do tell me that they do house visits, and they do see the patients in their environment. And I think house visits are very, very important in caring for patients with dementia. Like, we cannot be asking them to come to the hospital and seeing us here. Yeah, so I think carry on with a good job now.
Okay, doctor, sorry, there's one question just pop in. Does VDRL positive increase the risk of dementia?
Yes, it does. It does, because dementia, third stage dementia, that means dementia that's not treated, VDRL syphilis that's not treated adequately will lead to end stage dementia. So yes, so it needs to be treated aggressively. Yeah.
All right, so that's it, doctor. Thanks very much.
Thank you.
Okay, thanks everybody. Thanks all the doctors that joining the talk today. So stay tuned. We're going to have one next month. So we're going to announce it on Doc Witty soon. Thank you very much, doctor. Thank you.
You're welcome. Thanks for having me.